Hello and welcome. This lecture is about recognizing and managing suicidal and homicidal ideation in the pre-hospital setting. This is a critical topic for EMS professionals as you will encounter patients in mental health crises during your career. Our primary focus will be on suicidal ideation, understanding the warning signs, risk factors, and how to respond with care and compassion. We'll also touch on homicidal ideation, especially in situations where a patient expresses intent to harm others alongside themselves. By the end of this session, you should feel more confident in assessing these patients, responding appropriately, and potentially saving lives. The format will be conversational and scenario based, so you can easily follow along even without visual slides. Let's get started. First, let's understand the scope of the problem. Suicide is a leading cause of death in the United States. In 2023, about 49,316 Americans died by suicide, roughly one death every 11 minutes. For every death, there are many more people struggling. In 2022, an estimated 12.8 million adults seriously thought about suicide and 1.5 million actually attempted it. This is not a rare issue. It's something EMS professionals will encounter. In fact, about 5 to 15% of emergency 911 calls involve behavioral or mental health crises, including suicidal individuals. So if you haven't seen one yet, you likely will. Homicidal ideation, thinking about harming others, is less common, but it can co occur in severe crises. For example, murder suicide incidents, where someone kills others and then themselves, account for roughly 1,200 deaths per year in the US. While rare, these situations are extremely serious. Bottom line, recognizing suicidal or homicidal ideation quickly and responding appropriately is literally a life saving skill for an EMS professional. Your role isn't to be a psychiatrist, but you are often the first point of contact to get someone the help they need. Before we dive deeper, let's clarify some key definitions. Suicidal ideation means thinking about or planning suicide. In other words, thoughts of ending one's own life. These thoughts exist on a spectrum. Some people have passive suicidal ideation, like I wish I wouldn't wake up or feeling they'd be better off dead, but without a specific plan. Others have active ideation, meaning they not only think about dying, but might have a plan or intent to do it. As EMS providers, any talk of wanting to die should be taken seriously, but knowing whether there's a plan or active intent helps gauge immediacy of risk. On the other side, homicidal ideation refers to thoughts of harming or killing someone else. This could be specific, a patient naming an individual they want to hurt, or vague, I feel like hurting people. Sometimes these can co occur. For example, a patient might say they want to take someone with them, or get revenge on a person before ending their own life. This combined scenario, often termed a possible murder suicide situation, is especially critical for scene safety. We'll mainly focus on suicidal ideation for this training, but we'll address what to do if homicidal thoughts are present as well. Now, let's review some risk factors for suicide. These are factors that make someone more likely to consider or attempt suicide. The number one risk factor is a prior suicide attempt. If someone has tried to take their life before, it's a sign they could try again. Mental health conditions are another big category. Depression, most commonly, bipolar disorder, schizophrenia, severe anxiety, and others can increase risk. Substance abuse is often intertwined here. Drugs and alcohol can worsen mood swings and impulsivity, raising the risk of suicidal actions. Chronic physical illnesses or chronic pain can also drive people to despair. Major life crises or stressors are important too. Losing a loved one, going through a divorce or breakup, losing a job, serious financial problems, or legal troubles, like arrest or jail release, can trigger suicidal thoughts. A history of trauma or abuse, especially childhood abuse or exposure to domestic violence, is another risk factor. Additionally, if a family member died by suicide or if mental illness runs in the family, that can increase risk, whether due to genetic or environmental influences. Lastly, access to lethal means is crucial. For example, having a firearm in the home or a stockpile of potent medications makes it easier for a person to act on an impulse. As an EMS professional, you often won't know all these background factors on the spot, but any clues, family telling you about past attempts or finding lots of pill bottles, etc., can inform your assessment. Keep in mind, many people with these risk factors won't attempt suicide, but the more risk factors present, the more vigilant you should be, especially if you also see warning signs, which we'll discuss next. Let's talk about warning signs of suicidal ideation, starting with things a patient might say. These verbal cues can be direct or indirect, but all should raise a red flag. The most obvious warning sign is if someone is talking about wanting to die or kill themselves. It might be a clear statement like, I'm going to kill myself, or sometimes more vague like, I wish I were dead, or I think I might end it. Any such talk should be taken very seriously. Patients might also express profound hopelessness, sayings like, I have no reason to live, it's never going to get better, or there's no way out. They may describe feeling trapped or stuck with no solutions, or speak of unbearable pain, and this can mean emotional pain, like intense grief or depression, or physical pain that makes life feel intolerable. Another common theme is feeling like a burden. They might say, my family would be better off if I wasn't here, or I'm just causing everyone problems. These statements signal that the person believes others would be relieved by their absence, which is very concerning. Finally, pay attention to any kind of goodbye messages or preparation. If a patient is saying goodbye to people as if it's the last time, or you learn they've been making a will or final arrangements, giving away possessions, etc., those are strong warning signs. Essentially, listen for any language of despair, self harm, or finality. As EMS professionals, hearing these words from a patient means we need to act with urgency and compassion. Besides what a patient says, there are also behavioral warning signs, changes in what they do, that can signal suicidal ideation. One big red flag is withdrawal or isolation. The person may pull away from friends and family, stop responding to calls or texts, and quit activities they used to enjoy. They might also start giving away prized possessions or suddenly putting their affairs in order. For example, giving away a favorite guitar or cherished item, or suddenly drafting a will or final letter. These acts can indicate they're preparing for the possibility of dying. Another warning behavior is engaging in reckless or risky activities that they normally wouldn't, like driving dangerously fast, binge drinking, or other self destructive behaviors. It's almost as if they don't care about the consequences, which can be a sign of suicidal intent. Watch for extreme mood swings, too. Sometimes a person might be very depressed or agitated and then suddenly become calm or even cheerful. That might sound like a positive change, but in a suicidal context, a sudden calm can mean they've resolved to go through with suicide and feel relief that the end is in sight. We also often see increased substance use, someone drinking or using drugs more heavily as a way to numb their pain or pluck up courage to act. Other signs include heightened anxiety or agitation, or big changes in sleep patterns, insomnia, or oversleeping. If the person is experiencing psychosis or intense anger, they might show rage or talk about seeking revenge on people they feel wronged by. That last part overlaps with homicidal ideation, which we'll discuss, but it's worth noting here. Expressions of rage or revenge can mean the person is at risk of violence, to self or others. In summary, any dramatic change in behavior or mood in a person with emotional distress could be a warning sign. As an EMS professional arriving on scene, you might notice these signs yourself or hear about them from family or friends present. All of this helps you assess the situation. Now let's discuss how to approach the scene when dealing with a suicidal or potentially violent patient. Your safety and everyone's safety comes first. On any call with a psychiatric crisis, especially if there's mention of weapons or violence, make sure police are either on scene or en route. Upon arrival, ensure the safety of everyone present. That might mean having law enforcement secure any firearms, knives, or other weapons before you approach. If the patient has a weapon in hand or is in a dangerous location, like threatening to jump or in traffic, you must use extreme caution and typically wait for appropriate backup. Assuming the scene is secure enough to approach, don't rush directly at the patient. Take a slow, calm approach. Give them some space. If you have a team, avoid all of you crowding the patient. Too many people or a very fast approach can escalate someone's anxiety. It often works best to designate one person as the primary communicator who will engage the patient, while others hang back a bit. That primary person, maybe you, should start by introducing yourself. Hi, my name is Megan. I'm a paramedic. I'm here to help you. Use a calm, low voice, even softer than your normal indoor voice, and a friendly, compassionate tone. Try to be at eye level with the patient. If they're sitting on the floor, you might crouch or sit at a safe distance, so you're not looming over them. Use the patient's name if you know it. John, I'm here with you. This personal touch can help build trust. Very importantly, avoid any sudden movements. Don't reach out and grab them or startle them. If physical contact is not needed for medical care at that moment, give them autonomy over their personal space. If you do need to do something, like take a blood pressure or look at an injury, explain what you're doing first and get their permission if possible. For example, I'd like to check your pulse. Is that okay? This respectful approach is part of scene safety too. A patient who feels threatened or startled might become combative. So, to recap, secure the scene, approach slowly with one rescuer talking, use a calm and empathetic demeanor, and always be thinking about safety for you, your partners, bystanders, and the patient themselves. Building rapport from the first moments can greatly reduce tension and set the stage for a safer, more successful intervention. Once initial contact is made, You'll simultaneously need to manage any medical issues and the patient's emotional state. Address any serious medical needs first. For instance, if the patient has injuries from a suicide attempt, say cuts, a gunshot wound, or if they overdosed on pills, those need immediate attention. Follow your ABCs: airway, breathing, circulation come first. You might need to bandage wounds, administer Narcan for opioid overdose, etc. Do what's necessary to stabilize the patient medically, all while reassuring them. Next, ensure the patient is never left alone. One crew member should have eyes on them at all times. Suicidal patients can be unpredictable. Someone might suddenly try to run off or harm themselves when you're not looking. If you're a single responder, this means you might literally hold their hand or sit beside them while waiting for backup, or ask a family member to stay with them under your guidance while you grab equipment. The key is constant supervision so they don't take any sudden action. Also, make sure to remove any potential means of self harm from the immediate area. This could mean taking away a bottle of pills, a piece of glass, or scissors, anything they might use to hurt themselves. If there are toxic substances or empty pill bottles, collect them safely. This not only removes the danger, but also provides useful information to hospital staff about what they ingested. While doing all this, keep talking to the patient if they're alert. Engage them in conversation, or just listen, to keep them focused and prevent them from retreating inward. Often just letting them talk about what they feel can be therapeutic in the moment. Use that compassionate communication we discussed. Reassure and don't judge. As things come under control, our goal is to transport the patient to the hospital for further psychiatric evaluation and care. In almost all cases where a patient expresses suicidal ideation or attempt, they need to be evaluated by mental health professionals. Even if by the time you've treated them they say, "I'm fine now, I don't want to die anymore," we still encourage transport. Many EMS guidelines and common sense say any patient who is suicidal should be taken for evaluation. They might be involuntarily transported if they refuse and are a danger to themselves. The specifics depend on local laws and protocols. We won't dive deep into legalities here. Before leaving the scene, ensure any evidence or notes, suicide note, etc., are passed on to appropriate authorities or brought to the hospital, and try to gather some background info from family if present, without violating patient trust. During transport, keep the patient safe. Sometimes soft restraints might be used if they are highly impulsive, but only per protocol and as a last resort. Ideally, you continue verbal de escalation en route. Throughout, maintain that constant watch. Upon arrival at the hospital, hand off all information, including what the patient said or did, like patient said he took 30 Xanax and wants to die. This helps the ED and psych team plan appropriate care. Document everything thoroughly in your report. It might feel routine to you, but your documentation might later be crucial for ensuring the patient gets proper follow up care. The big takeaway for on scene management is treat the body and the mind together, handle medical issues, keep the patient and scene safe, and get them to definitive care while showing them compassion and hope. A critical component of these situations is how we talk to the patient. Compassionate communication can de escalate a crisis, build trust, and make the difference between a patient cooperating or not. First, listen actively. Let the patient talk about why they are feeling this way if they are willing to share. Sometimes just letting them vent or cry while you listen is incredibly therapeutic. Validate their feelings. This means acknowledging that their emotions are real and important without necessarily agreeing with their conclusions. For example, a patient might say, "I just can't go on. I lost my job and my spouse left, and I feel worthless." You can respond, "I hear you. You've been through a lot and it sounds so overwhelming." Phrases like that show you accept that they are in pain. Do not judge or criticize the person's feelings or actions. Avoid saying things like, "That was a stupid thing to do," about an attempt, or "You shouldn't feel that way." And definitely don't use cliches like "snap out of it" or "other people have it worse." Those are minimizing and can shut the patient down completely. Even if you're trying to cheer them up, saying, "Come on, it's not that bad," can feel dismissive. Instead, express empathy. You might say, "I'm so sorry you're feeling this much pain," or "It sounds like you're feeling very hopeless right now, and I'm really sorry you're going through this." Showing genuine human care can build a bridge. Let them know that you care about their well being. Sometimes just saying, "I care about you and I want to help keep you safe," can be powerful to someone who feels alone. Also, reassure them that they are not alone right now. You might say, "I'm here with you. I'm not going anywhere. We're going to get you some help." The knowledge that someone is standing by them can reduce the immediate sense of isolation. However, be careful not to make promises you can't keep. "Everything will be fine," or "This will all be fixed tomorrow." We don't know that. Stick with hopeful but honest reassurance, like stating that help is available and that suicidal feelings can be treated. If the patient is expressing irrational statements, say extreme guilt or seeing no hope, do not directly argue with them. "No, you're wrong. Your life isn't that bad." Instead, gently offer a different perspective. I know you feel like there's no hope. I've seen other people get through things like this, so I believe there's a chance for things to change for you too. Let's focus on getting you some help. Keep your voice calm and patient. Even if the patient yells or insults you, don't take it personally. It's the pain talking. If family are present and agitated, you might also need to calm them and maybe have them step aside if they're making the patient feel judged. Another tip: if law enforcement is on scene and their presence is making the patient uncomfortable, which is common, see if officers can stay a bit back once safety is secured. People might open up more without a police officer right next to them. Throughout the interaction, the mantra is compassion over confrontation. You want to collaborate with the patient, not battle with them. By treating them with dignity, empathy, and respect, the same as you would for someone with a visible physical injury, you help reduce their fear and shame. This not only makes the scene safer and the transport smoother, it's just the right thing to do for a fellow human in crisis. Many patients later say that a kind word from a first responder made a huge difference. So, remember, your compassionate approach is as important as any medical treatment you give. Now, let's address the secondary focus: homicidal ideation, especially when it co occurs with suicidal ideation or other psychiatric emergencies. Homicidal ideation means the patient is having thoughts of harming or killing someone else. This could range from vague statements like, I feel like hurting people, to very specific threats such as, I'm going to kill my neighbor. These situations add a layer of complexity and danger to the call. Often, homicidal thoughts in a patient come from extreme anger, feelings of persecution, or a desire for revenge. For example, a suicidal patient might also be enraged at someone who wronged them, a spouse, a boss, and say things like, I'll make him pay before I go. In other cases, it might be linked to paranoia or psychosis, hearing voices telling them to hurt others, or delusional beliefs that someone is out to get them. As soon as there is any indication of homicidal intent, scene safety becomes even more critical. Your first move should be to ensure law enforcement is present or en route. If a patient has made direct threats to others or is armed, police absolutely need to secure the scene. As an EMS professional, do not attempt to handle a potentially violent individual alone. Once safety measures are in place, your approach is similar in many ways to what we discussed. Use calm verbal de escalation. Don't confront or argue about their threats, and try to get them talking. However, maintain a higher level of caution. Keep a bit more distance, have an exit route in mind, and coordinate closely with law enforcement on a plan. If the patient is extremely agitated and verbal de escalation isn't working, the team, EMS and police, maybe with ALS if available, might need to employ physical restraints or chemical sedation per protocol for everyone's safety. This is a last resort, but patient actively threatening to kill someone could necessitate it. From a medical legal standpoint, a patient expressing homicidal intent and having means usually will meet criteria for involuntary hold. But again, that's for law enforcement and the receiving hospital to sort out. Your job is to safely transport. It's important to note, even if someone has homicidal ideation, they are still a patient in crisis, not a criminal in that moment, unless they've already committed a crime. So continue to show empathy and respect once the immediate threat is controlled. For instance, if a man says he wants to kill his boss and himself, you ensure he has no weapon and police have him secure, then you might say calmly, I understand you're feeling a lot of anger. I want to help you stay safe so no one gets hurt. Let's figure this out at the hospital. You're not approving of his threat, you're just acknowledging his emotion and refocusing on safety. Always avoid statements that could escalate violence. Don't say things like, if you do that, you'll ruin your life, or you're going to be in big trouble. Instead, keep him engaged. Tell me what's going on, or I want to help you, but I need you to stay calm so neither of us gets hurt. Remember, rage and talk of revenge are major red flags. They indicate a person who might act impulsively. So these scenes require teamwork with law enforcement, vigilance, and a lot of de escalation skill. In summary, homicidal ideation equals safety, safety, safety. Protect yourself and others first. Use the same compassionate approach when you can, and ensure this patient also gets to the hospital for urgent psychiatric evaluation. They may end up in custody or under psychiatric hold, but from the EMS perspective, our role is to care for them medically and mentally until we hand off to the next level of care. Join me in the next section to continue our discussion by applying the knowledge you have gained. See you then.